Good afternoon, everyone. So welcome to the afternoon session today. And again, many thanks to everybody for attending on a Saturday. We very much appreciate that. On behalf of Boehringer Ingelheim and Eli Lilly, we would like to welcome you to the afternoon session of this very exciting event. Now, again, we have three different audiences. Firstly, we have where the speakers are, our site in Sydney. Then we have multiple venues across Australia, also face-to-face. And then lastly, we have online for the webinar version, both Australian GPs, and also we're very excited to have join us this afternoon, multiple other countries across the Asian region. So we have all of our colleagues from the Asian region who have joined online. So I'm sure we'll hear from them in question time. So as far as questions goes and for polling, on the screen right now, regardless of what venue you're at and what location you're at, is the QR code that we'll be using for our questions and polling. So for those of you in Sydney, please don't use the QR code on your table. And for everyone, wherever you are, please just use the QR code that's on your screen now. And just scan that. I'll just give you a few seconds to scan that. So again, if everyone, whichever audience you're at, if you just scan the QR code that's on your screen now. And now it gives me great pleasure to introduce Dr. Anita Sharma. Anita is a GP based in Brisbane in Australia, in Queensland. And Anita is, from an Australian perspective, is a GP that is part of the Diabetes Special Interest Group with the Royal Australian College of GPs in Australia. So welcome to Anita.
Thank you. You must be wondering, it's like deja vu all over again, but we're doing this for the benefit of people who've just joined us online or who've come this afternoon. So welcome to everyone here and online. So we have, again, I'm going to introduce our speakers for the benefit of people who weren't here this morning. We have a really fantastic lineup of very distinguished, eminent physicians today who are going to talk to us about different topics relating to heart failure, kidney disease, and diabetes. So I'll start with Professor Andrew Coates, who is a very eminent cardiologist, who is the immediate past president of the Heart Failure Association of the European Society of Cardiology. He is also the director of the Monash-Warwick Alliance and academic vice president of Monash and Warwick Universities. Welcome, Professor Coates. We have also today, all the way from the UK, Dr. Janaka Kairaledi, who's a very renowned physician in the UK and does a lot of, I think, global work. He is a clinical reader in diabetes and cardiovascular disease in the School of Cardiovascular Medicine Sciences at King's College London and consultant physician in diabetes and endocrinology and internal medicine at St. Guy's and St. Thomas Hospitals, London. We've got Associate Professor Bobby Chacko, who is a very distinguished renal physician, and he's the director of the Renal Services and Senior Staff Specialist, Nephrology and Transplantation at John Hunter Hospital in Newcastle. And then we've got Dr. Ted Wu, who is one of the very well-known educators here in Australia, very active in involvement of both GP and advanced trainees. He's a senior specialist endocrinologist and director of physician training at the Royal Prince Alfred Hospital in Sydney, Australia. So welcome to all of you today. So we are, I guess, now going to move on to the afternoon session, and we're going to talk about the burden of cardiorenal conditions in type 2 diabetes. Over to you, Dr. Janaka.
So thank you very much, Anita, and if I can get my slides up. So it's a great pleasure to speak to you all today, and I'm going to focus about cardiovascular disease, kidney disease, and diabetes, and the interconnectivity that we all heard about this morning, and why it's so important in a practical sense of identifying people early who share these common comorbidities, but also intervening promptly with evidence-based, guideline-based treatments. These are my disclosures. So I'll start with a picture of where I work, but about 500 years ago. This is Guy's Hospital. It was started to look after the poor of people of London who could not afford healthcare at that time, which was the privilege of the wealthy, until we had the formation of the NHS after the Second World War. So the hospital has changed over time. I often wish there are two buildings. I work in the more Soviet-style building that you can see on the right, but the Shard and the Shangri-La Hotel is right next door to us, owned by the government of Qatar, with the five-star hotel at the top. And I do clinics in the less elegant building to the side of it, looking after people with diabetes and kidney disease and cardiovascular disease. 3 to 4 clinics with a large proportion of patients with more advanced complications, generally with stage 4 or 5 CKD, with heart failure and progression towards kidney disease, unfortunately very common. So on a good day, I also work on a good day. There's a picture to work across the South Bank. That's Big Ben. And I work at St. Thomas's, again, focusing on heart failure and diabetes clinics, which we work together. But something that we're really focused on is, even though central London may appear prosperous and glamorous, where we work in South London has a huge amount of deprivation. So the boroughs that I look after in South London are in the top 10 most deprived boroughs in terms of economic indices and a life expectancy that is 5 to 10 years lower than the national average. And more than half my patients are of non-Caucasian origin. And we have a high-risk population, early onset type 2 diabetes, very aggressive kidney disease, very aggressive cardiovascular disease. And what we've done in the last 5 years is deliver community-based complication services where the hospital team goes to primary care, but also actively searches through GP databases, which we are fortunate to do because we have shared electronic health records, one of the a few good things about the NHS, but we have shared IT, and we're able to access and identify high-risk people to triage at the level of primary care, and then inform and guide our primary care colleagues. And the clinics we run are multidisciplinary, with a GP, with special interest in diabetes and heart failure, and we have renal trained dialysis and diabetes nurses, a heart failure diabetes pharmacist, and other associated healthcare professionals who really guide a multidisciplinary service based in community centers across South London. And why do we do it? And I guess this is a picture that I often love to show, and I think is really important, and this is about doing simple things well. This is a picture of an elegant physician from the Canterbury Tales, useful school-based reading for those in secondary school. And if you were an elegant physician 600 years ago who had patients queuing up to see you in your private practice, you needed to have 3 key ingredients. You needed to have a beautiful horse, clearly, a beautiful gown, but most importantly, you had what's called an accoutrement, which is another word for a fashion accessory. It's the equivalent of your Gucci or your Versace bag, but it's a leather flask looking at urine. And urine analysis gives you a picture. It's a window into your body, not only acute disease, but chronic disease. And the importance of urine analysis was appreciated hundreds and hundreds of years ago, even before this, and highlights what we should be doing much, much better. So how are we doing 600 years later? The reality, this is data from the US, and it's sadly replicated across the world, is we are not doing the basics well. Less than 50% of our patients with diabetes get an annual urine ACR test done. And we are diagnosing chronic kidney disease, sadly, when we have lost 50 to 60% of kidney function. And the reality is that early identification of albumin in the urine is still a very important biomarker to predict not only kidney disease, but also cardiovascular disease, and something we should do so much better. And what we know in terms of chronic kidney disease, as you can see here, in terms of the stages of kidney disease, it's the GFR, which is an estimate of GFR from serum creatinine and albuminuria. And you have this heat map. As your GFR declines and your albuminuria goes up, you not only have elevated renal risk in terms of progression to kidney disease, but you have massively elevated cardiovascular disease as well as heart failure. My heart failure colleagues have more recently started testing urine albumin as a useful biomarker because high levels of urine albumin actually predict rehospitalization on top of standard biomarkers. And what we can see here is the importance of measuring kidney function and urine analysis. So if your GFR is above 60, you have to have evidence of kidney damage, be it abnormalities in albuminuria, a family history of kidney disease, abnormalities on imaging, or genetic disease. If your GFR is below 60, you need 2 values to confirm the diagnosis of CKD, which should always be in a clinically stable situation. It's not a diagnosis you make in an acutely unwell patient. And something we emphasize with our colleagues in London is getting the diagnosis right. Because if you misdiagnose someone without evidence of kidney damage, just because they have a GFR of 70 and there's no evidence of kidney damage, they do not have CKD. But once you put that label of CKD, it's really hard to take it out. So when they go for their travel insurance, or their mortgage, or their pension, they don't care about the stage of CKD. You see CKD and you don't get your mortgage and your insurance. So if your GFR is above 60, you have to have evidence of kidney damage, be it in the urine, be it a structural abnormality or a genetic disease. If it's below 60, you need 2 values in a stable situation to confirm the diagnosis. You do not need to have the evidence of kidney damage per se. And as we saw this slide earlier, our patients have multiple comorbidities. And I guess the key message is the heart and kidney are interconnected. It's like a happy or unhappy marriage. If one is unhappy, the other is unhappy. If you improve kidney function, you will improve cardiac function. If you improve renal function, likewise, the cardiac function also gets better. And these are 2 symbiotic organs. And when you have diabetes, which aggravates through hyperglycemia, pro-inflammatory pathways, inflammation, you have double damage affecting both the heart and the kidney, and the presence of diabetes increases your burden of kidney and cardiovascular complications. So the reality, and we heard about this today, is that our patients do not sit in silos. They do not exist with one disease. We have something called comorbidity and multimorbidity. And the reality is that we have diabetes, we have chronic kidney disease, we have ischemic heart disease, we have heart failure. And our patients have shared comorbidities, and we are fortunate now to have medications that we can use across these specialist areas. And I guess the key message here is thinking about how we work. And something we are very keen to do, it's still at early stages, is the concept of making every contact count. And what I mean by that is every time you see a physician, be it a GP, a diabetes doctor, a kidney doctor, or a heart doctor, we need to think together, what can we do to improve outcomes? Duplication of care is not good. It's inefficient. Patients don't turn up to appointments, and patients have to often wait months and months to see specialists. What we're trying to do in London is to think of this one team approach, that one patient has lots of diseases, and every contact we have with the patient should count for us to assess, diagnose, and act promptly. And the reality is that heart failure, chronic kidney disease, these are very, very common, even in patients who have well-controlled diabetes. So think beyond the HbA1c. Think of the patient with diabetes as a very high-risk patient for cardiac disease, heart failure, and chronic kidney disease, even in the context of glucose control, which objectively on a measure looks good. There is silent damage happening or has happened already to the heart and the kidney. And something we're very keen on, again, which I think is similar across the world and even in Australia, is the devastating impact of young onset type 2 diabetes. So the youngest patient I have on dialysis with type 2 diabetes is 29, biopsy-proven kidney disease, African Caribbean, hypertension, rapidly progressing kidney disease. My African Caribbean patients with this rapid decline in GFR are also similar, though they look very different, to my Asian patients. So half my patients, as I said, are non-Caucasian. We have patients who have moved from Asia, from Hong Kong, Vietnam, Philippines, to the UK, and we have South Asian patients. And we have a phenotype of patients who get young onset type 2 diabetes, who have a rapid progression, often with hypertension, lots of protein in the urine, and this rapid decline. And the presence of young onset type 2 diabetes means you've got a very high-risk patient in front of you. And look at the loss of life. There's loss of life across age groups, but the presence of early-stage chronic kidney disease makes you lose between 10 to 15 years of life, which is so, so important in terms of offering kidney-saving, cardiac-saving, and life-saving interventions. So if you are a kidney doctor or interested in diabetic kidney disease, I don't have the beautiful slide that Andrew had with all the wonderful cardiovascular trials. We've been rather less privileged in the kidney world. We have the wonderful studies, and I think the history of medicine teaches us a lot, so I'm a fan of it, so apologies, but there were studies in the 1980s from Morgensen and Parving in Denmark, which demonstrated the really important concept, which we often forget now, that blood pressure lowering per se prevents kidney disease. They didn't have the wonderful drugs we had in the 70s. They had beta blockers and hydralazine, but the concept that lowering blood pressure stops your kidneys progress into kidney failure is really important. We then had the ACE inhibitors, the Captopro study in Ed Lewis in people with type 1 diabetes with proteinuria, and then we had the irbesartan studies and the losartan studies in people with type 2 diabetes, and these were the last drugs licensed for diabetic kidney disease more than 20 years ago. And we've had multiple failures en route, and now we have, like things, you wait and you wait. These are buses in London, which you can wait for a long time. Things are better, but finally things arrive in together. We have SGLT2 inhibitors, which we can offer patients with kidney disease. We have finerenone, which is a mineralocorticoid antagonist, a posh version of spironolactone, if you like, with less hyperkalemia, and potentially GLP-1 receptor agonists, which have cardiovascular benefits, but are being evaluated for renal benefits downstream. And in terms of the SGLT2s, we're focusing on empagliflozin here in this discussion, and this sits right at the top, in my view, in the context of people with type 2 diabetes in the SGLT2 inhibitor class, because it ticks your mortality, your 3P MACE, your cardiovascular death, your hospitalization for heart failure, which we heard earlier, renal outcome studies, as you will hear very soon in the near future, and all-cause mortality as an SGLT2 inhibitor within type 2 diabetes, demonstrating benefits for all-cause and cardiovascular mortality, the only one in type 2 diabetes to do this, but also heart failure and renal benefits in people with and without type 2 diabetes. And we saw the slide earlier about heart failure with reduced ejection fraction, and I really want to push these time slides because what I want to emphasize here is not to delay. So you saw the heart failure benefits emerging within 2 weeks, right? And the question is, why are we waiting and waiting for starting these drugs? We are delaying stuff that actually works within weeks. Why are we waiting 6 months or a year when a drug works in 2 weeks? And this is cardiovascular mortality. And you see the benefits within 60 days in people with type 2 diabetes. So the concept here is not waiting and waiting, but acting promptly, because these drugs don't take 5 years to show benefits. They show benefits within weeks and months, and that's a key message in terms of interventions. So what about patients who have kidney disease? As I said, once you have CKD, unfortunately, most people will die of cardiovascular disease. When I do my dialysis clinic and I have a fellow sitting in with me, I say, listen, you're now seeing the patients who lived long enough to end up on dialysis or transplantation. Things are improving, we're doing much better, but still the majority of people with chronic kidney disease, CKD 3, 4, will die of cardiovascular disease or another cause before living long enough to end up on renal replacement therapy. So chronic kidney disease on its own is a cardiovascular risk factor. And we have data from the EMPA-REG outcome study to show that even in people with a GFR below 60 or elevated albuminuria, which defined chronic kidney disease, you get the mortality benefits in patients with type 2 and chronic kidney disease. What about renal outcomes in people with heart failure? So when I do my heart failure clinic, we heard about these changes in kidney function. And when you've got diabetes and you've got heart failure, everything is worse. So once you have diabetes, your heart failure and your kidney disease progresses much more rapidly, as I said. And the heart failure patient is very vulnerable for changes in kidney disease and kidney function. So if you have a patient with heart failure with reduced ejection fraction, we saw this data earlier in terms of the utility of empagliflozin across a spectrum of ejection fractions. I'm going to focus a little bit on renal outcomes. And here is data for people with heart failure with a reduced ejection fraction. This is the placebo group. So remember, in these trials, everyone got best care. At that stage, it was your ACE or your ARNI, your beta blocker, and your mineralocorticoid antagonist. And then in one group, you had the SGLT2 inhibitor, empagliflozin, added on top of standard of care. And this is renal adverse events defined as a 40% drop in eGFR with a sustained eGFR below 15 mils per minute. What this shows you is that when you have diabetes, your risk of kidney events, if you have heart failure with reduced ejection fraction, is 2 to 3 times greater than someone without diabetes. So remember that diabetes per se doubles or trebles your risk of adverse kidney outcomes, drop in eGFR in people with heart failure and reduced ejection fraction. So what does your intervention do? When you give empagliflozin, what you can see is your risk of renal adverse events on top of standard of care in people with heart failure with reduced ejection fraction. You're reducing your risk almost to the level of placebo in people without diabetes with heart failure with reduced ejection fraction. What does this mean? It means that empagliflozin eliminates the excess renal risk attributable to diabetes in people with heart failure and reduced ejection fraction. And this is why these drugs are game changers. They're not only preserving heart failure with reduced ejection fraction and preserved ejection fraction and preventing hospitalization, they're also translating to kidney benefits that are really meaningful in practice, but also important in terms of patients with diabetes and heart failure. So this is a simple algorithm. We have debated this earlier, and I apologize if this is rather too simplistic, but this is what we do in our primary care clinics for people with heart failure, and we run heart failure community clinics often with GPs, and it's about offering a simplistic approach. I appreciate there are nuances and there are always things that are not as straightforward, but we think that simplicity is often the ultimate sophistication in terms of what we can offer for medical education. So it's about looking, and the reason we do this is that these are patients with heart failure who are stable, they haven't been hospitalized, they're not having regular appointments, they are heart failure with reduced ejection fraction that are stable in the GP practice, who have been discharged from the hospital regular follow-up system but have a surveillance program. We assess the volume. I'm proud to say that I still think that medicine is an art rather than a science, and I really push for clinical examination. We still have very strict clinical examination exams, at least in London, and stethoscopes, assessing the JVP, assessing the peripheral edema, doing the basics really well, I think is so important, because we do not have access to echoes and ECGs, etc., at the drop of a hat. So we assess the volume, we look at the blood pressure, and what we do is we assess the patient who's hypotensive, who has evidence of volume contraction. We will look at the loop diuretic and hold and maybe not start the SGLT2 directly, or ask our heart failure experts if they think they would want to review. If the patient is euvolumic and normotensive with no significant drops in postural blood pressure, which in my view is still quite important and something we should do better, we will reduce the loop diuretic, but we give advice to the patient that if they get breathless or they notice their weight going up, we're very keen in our heart failure patients doing the weight at home. Not everyone does it, but some do. And if they notice the weight going up and they get breathless, when we have reduced their loop diuretic, to go back on the higher dose and then call us. If they're overloaded and hypertensive, we add the SGLT2 and then have this review. And this is a simplistic approach, but again, practical, to not have this 6-month wait to see someone again to initiate an evidence-based therapy, which many of my GP colleagues, as you've heard, have been using for 10 years, and who also have to do the clinical exam because they don't have the ECGs and the echoes to hand, and it's still very valuable. What about diabetes? So again, I don't want to see every patient referred from the cardiac and renal teams to start an SGLT2 inhibitor. I think these drugs can be started by everyone. And, and I think for our cardiology and renal colleagues, we say, can you please check, are they on an insulin or sulfonylurea? That's quite important, because these are drugs that cause hypoglycemia. And if you've got heart failure or CKD, that's not very good. What is the A1C? If it's more than 8%, and the kidney function is more than 45. Remember, these drugs lower HbA1c only when you've got preserved renal function. If you've got a GFR of 60, you pee out or excrete about 120 to 160 grams of glucose. If you have a GFR below 30, you only excrete 10 grams of glucose, and that's why you don't get the HbA1c drop when your GFR is below 45. So if you've got a patient with a GFR over 45, with an HbA1c over 8, you would add the SGLT2, but if the HbA1c is below 8, we make sure our heart failure colleagues in the community give the patient a blood glucose meter, the simple things, a leaflet about hypoglycemia, contact details for the community diabetes team, and if they're driving, to remember that they need to check their blood sugars when they're driving if they're on insulin and sulfonylurea, because we have strict rules in the UK. And then they reduce the dose of the sulfonylurea by 50%, make sure the patient is checking the glucose. If the glucose levels go back up, they can go back on the glycoside, and similarly with the insulin. If the patient is not on insulin or sulfonylurea, you just add the drug, and that's it. And in the UK, we are fortunate where we can add it independent of the baseline HbA1c, which I know has to be 7% in Australia, but we can add it for the cardiorenal benefits. This is what we share with our GPs. Again, apologies if this is rather simplistic, but this is really important about safe prescribing and educating our colleagues, because everyone has questions. And the question is, who should we be cautious about? But something I'm very passionate about is looking at age, as Anita said, in a more sophisticated, nuanced way, and assessing frailty, which is done very well in the UK. We have lots of frailty scores, but thinking of the concept of biological age. And I give you the example of my next door neighbor who's 82. He plays 2 rounds of golf. He drives. He definitely walks faster than me. He picks up his grandkids 3 times a week to help his children. He's on his passport, he's 82, but biologically, he's probably 60. My dialysis patient who's 55 on his passport is biologically 80. And we need to look at age in a much more focused way, because older people are living longer, and many of them have excellent quality of life, and we should not deprive these patients, especially those who are at high risk of heart failure and cardiovascular disease, of evidence-based treatments just because we don't have all the trial evidence. Assess age in a very focused manner. We are careful in people, obviously, with type 1 diabetes or pancreatic disease causing diabetes. If a patient has active foot sepsis, needing antibiotics, under the hospital team, hold fire, because these are sick patients. They have often imaging, they're on antibiotics that they make feel nauseous, their kidney function goes up and down. It's not because the drugs are harmful per se, but just be careful. If they're on ketogenic diets, which are very fashionable, we hold fire temporarily. We worry about the patient who's insulin deficient. This is not a drug to replace insulin, but if the patient is losing weight and the HbA1c is high, refer or discuss with your local diabetes stream. And obviously the history of DKA. We have guidelines for people in hospital, which may not be directly relevant to all of us, but we have guidelines where if you're having major surgery, laparotomy, you're nil by mouth, you're having IV fluids, you suspend the treatment for 24 to 48 hours prior to surgery, and you restart the drug when the patient is eating and drinking. The only situation in acute medicine where we continue the SGLT2 at my institution is acute heart failure, where we continue the drug. But every other acute emergency, you've got to be pretty sick to get admitted to a hospital in the UK, especially in London, where we don't have many beds that are free. But if you're sick enough to come into hospital, we stop and we restart at the time of discharge. And we write to the GP, if we are starting the drug, why we started it. Communication from the hospital to the GP is shocking in London and across the UK. I don't know how it is here, but we have to help our colleagues know why we started the drug. So I say, this drug has been started for heart failure. Do not stop unless you speak to the heart failure team or the diabetes heart failure clinic. This drug has been started for chronic kidney disease. Do not stop unless you're spoken, because these drugs have lots of indications, and it's very tough for GPs to know. And we as hospital specialists, if we initiate this stuff, especially on our discharge summaries, we have to be clear. We don't need to write 100-word essays. It's why we started the drug and why not to stop it. It's so, so important. So we also spend a lot of time on sick day rules. Every patient I see in the community clinic, we give them a little card of what to do when they become acutely unwell, and we have these sick day rules. I'm fortunate, again, to have a heart failure pharmacist with me who runs through the medication to talk about compliance. Most of our patients don't take their tablets. They don't even know why they're taking some of their tablets. If you don't explain why this drug is working and how it is helping you, people may not want to take it. And they have advice on what to do when they're acutely unwell, but most importantly, to restart your key therapies that are really, really important. We have non-steroidals there because a lot of patients take non-steroidals. It's not a sick day rule drug, but these are terrible for your heart and kidney. It's one way of figuring out from our patients, are they actually on non-steroidals, and making sure they don't top it, but also give advice on other therapies. So just to end on terms of why we think this is important and how we change our practice is, as you know, the UK after Brexit and recent economic struggles is getting poorer by the day, and medicine and diabetes is expensive, right? 10% of the NHS budget goes on diabetes. That translates to £1.5 million an hour. It's probably gone up as I've spoken, but it's £1.5 million an hour is spent on diabetes. But 80% of the cost of that 1.5 million is complications of diabetes affecting the heart and the kidney. Complications cost patients in terms of quality of life, but if you live in an economically demanding environment like us, it also costs money to everyone, not only the patient, but wider society. And that's why we have NICE, which uses evidence, but also uses another E, economics. Evidence plus economics to guide delivery of healthcare. Is your intervention cost effective? Plus, does it have the evidence for cost effectiveness? So these are the recent updates, which is really important for our GPs, because one of my GPs said, we did a talk about guidelines, and he said, do you know how many guidelines I have to read? And I said, I don't know. I'm not going to give you the number, but if I print every single guideline I have, not just diabetes, psychiatry, obstetrics, occupational health, pediatrics, it's 15 kilograms. And these are not the abbreviated guidelines. These are the guidelines written by many people, 300 to 300 words. And it's 15 kilos, right? So simplicity is important. This is the NICE guidelines, which they're not perfect, but we're getting there. So it's about assessing, independent of HbA1c, your cardiovascular and renal risk. And if you are high risk, which is defined as, this is really primary prevention, we could argue about the evidence, but high risk means you have a Q risk score, which is an equation our GPs do to assess cardiovascular risk based on traditional risk markers. But if your Q risk score means you're on a statin, by definition, you should be on a SGLT2 inhibitor. That's it. So my message to my colleagues in primary care is, if you've got a patient with type 2 diabetes who's on a statin, they should be on a SGLT2 inhibitor. You've got the people with established cardiovascular disease, which is different, but the key message is after metformin, you add the SGLT2 within 8 weeks. And this all comes down to economics. GLP-1s are not here because they're too expensive. And bang for your buck, SGLT2s are more cost effective and prevent complications, hence second-line use in the UK, which will make a huge difference to how we approach healthcare. And this is important because this is an example of one of my patients. This is his GFR over time. He attends all these clinics. He comes to me when his GFR is declining from 38 to 31. These are the number of appointments. And we have this inverse care law in the UK, where most of the attention a patient gets is when they have irreversible disease. The number of his appointments goes up exponentially. The cost, the patient doesn't pay, as you know, in the UK. It's free for the patient, but we all pay through taxation, indirectly or directly. Someone pays. This is the cost per all those appointments. And you can see he ended up on dialysis. He's now had a transplant, but we now have this impact of what his disease is doing in terms of healthcare utilization. And also forget, we can't put a price on his quality of life here, right? This is just the economics we're talking about. So remember, this is a view from the Shard. I haven't stayed there. I don't know if my cardiology colleagues do, but I haven't. But this is the Shard overlooking London. Amazing hotel, from what I've heard. Shangri-La at the top, 24-hour butlers, lots of Michelin-starred restaurants, infinity pools, etc. That's Guy's Hospital bed. Not that nice. You don't really get a good choice of food if you feel like eating. Definitely no butler service. You're lucky to get one-to-one nursing or any kind of one-to-one attention. That's the cost of one night at the Shangri-La. That's the cost of one night at Guy's Hospital. And this is not just the bed. It's the doctors, the nurses, the staff, the medicines, everything. And I'm talking about money here, but also we haven't put quality of life and what this means. But I put this in terms of what should we really be doing in terms of our intervention is think about the quality of life of our patients, but also the long-term impact beyond just the patient and economy. And it's thinking about value. And when we look at medications, not just about cost, short-term cost, but does your medication add value? What I mean by value is, does it actually make a difference to patients' quality of life, their complications burden, how they feel, prevent healthcare utilization, not just cost, but value of your intervention, be it a new treatment pathway, a new clinic, a new medication should be assessed on value that it adds to patients with diabetes. So, what do we tell our GPs? If you had a patient post-MI, you wouldn't be thinking about a statin or not. If you've got a patient with high cardiovascular disease, you offer them a statin. Think, why is this patient not on a SGLT2 inhibitor? Give me a good reason why they're not. Think, what is stopping me from prescribing evidence-based medications that actually make a difference, not in terms of short-term measures, but actually clinically relevant symptoms and disease. So to conclude, when we have patients with heart disease and CKD, lots of things are happening. Sadly, many of these things are asymptomatic, so we pick things up late. Remember the horseman and the elegant physician. Remember to check the urine, identify your urine ACRs, look at your eGFR trends. Clinical inertia, as we heard from Ted, this is delaying, it's procrastination. None of our healthcare systems are perfect. We all have inherent inefficiencies, but what are we doing delaying treatments? Why aren't we offering treatments to our patients promptly? We have a simple treatment of a single dose which doesn't require dose titration, which actually works within weeks. 2 weeks for heart failure, 60 days for cardiovascular mortality. And what we should be thinking about is not just think about the HbA1c, what does our intervention do in terms of quality of life, burden of complications, and ultimately improving the quality, but also the longevity of people with type 2 diabetes we all look after. So thank you very much for your attention.
So I think we might, do you want to present the paper?
If we get some, we can have some,
Okay, so the way it's running on the agenda, and then we'll do, So we might get Dr. Wu to come over and do his presentation.
Okay, thank you very much, Janika, for an incredibly insightful presentation. We're going to go through to my one now before we go back to that case. Okay, so there we go. So what we'll be talking about is something that we've been talking about a lot today already, which is guidelines. As Janika has said, there's more than just one disease state with guidelines, and even within one disease state like diabetes, there are multiple guidelines. And they sometimes say the same things, and they sometimes say different things, okay? And they change all the time. So it's really, really hard to keep on top of everything. I understand that. But what I'm going to try and do is I'm going to try and give you a very top line sort of understanding of what the latest guidelines are from Europe, from America, and a couple from Australia, and how they pertain to diabetes management in 2023, and how we're thinking about what order we use our medications in type 2 diabetes. So here are my disclosures. And let's just quickly have a brief history lesson. Let's go back to the type 2 diabetes guidelines from the American Diabetes Association in 2006. And what you can see there at the top is that you diagnose it and you give people metformin, and if the HbA1c is over 7%, then you do something else. Okay, so at the very top line there, you can see this is a very what's called glucose-centric view of things. Everything came back to glucose. You didn't do anything unless the glucose was high. And as I was saying to the people who were listening to me in the morning, this is a focus on failure, okay? You don't do anything until the patient is failing their HbA1c, which is a very reactive way of doing things. But nonetheless, what should you do if the HbA1c is above 7%? Well, you could add basal insulin, you could add sulfonylurea, you could add glitazone, and then after that, if you were failing again, you added whatever you didn't add in second-line therapy. The other major thing that you can get from this, other than the fact that it's a very glucose-centric approach, is that it's very much metformin first. Metformin, metformin, metformin. Now, this was new to the Americans at the time. They used metformin much after we did. And so therefore, it was a new kid on the block for them. They were very excited about metformin, but it was without question, metformin was the first line of treatment, and then a few other options after that. Let's fast forward to today. 2023. And this is the equivalent guideline for the American Diabetes Association, which they did alongside the EASD, the European Association for the Study of Diabetes. Now we will focus on certain aspects of it, the right side and the left side. But basically what it's saying is that when you are diagnosed with diabetes, don't forget the lifestyle. It's really, really important. Think about all the psychosocial, educational aspects. Think about the social determinants of health. That's very important. But what do you do after that? This guideline asks you to ask one single important question. Is the goal to try and decrease the cardiovascular and renal risk, so the cardio-renal risks of this patient? Is it your number one priority? If it's your number one priority, go down the left side of this diagram, underneath the green sort of long bar at the top. And then you follow the guidelines there. We will focus on that in a little while. But if the goal is not to focus on cardio-renal medicine, okay, the interplay between cardio-renal and metabolic medicine, and just to think about metabolism, so i.e. the more glucocentric part of the pathway, then you go on to the yellow greenish side on the right-hand side of the diagram here. Again, you'll agree that this is not so glucocentric. We're thinking outside just glucose, but we're thinking the first question is the patient at high risk of the interconnection between metabolic disease, that is glucose, cardiac disease, and renal disease? So because that's the most important part of this diagram, let's look at the left side of this diagram first. Let's blow it up here a little bit. So it says, if our goal is to focus on the cardio-renal risk of this person with type 2 diabetes, okay? And there's various ways of assessing risk. I won't talk to you about how to assess the risk, but let's just say you determine, maybe from Janika's suggestion, should the patient be on a statin? If they should be on a statin, they're at relatively high risk. So think about that sort of patient. It then subcategorizes this cardio-renal sort of complex into different types of categories. There's ASCVD, so that's atherosclerotic cardiac disease in the blue, heart failure in the red, and CKD, or chronic kidney disease, in that brownish color, brownish orangey color to the right. So what does it say? If the patient has either established ASCVD in the blue or high risk of ASCVD, i.e. on a statin, let's say multiple risk factors, then what should we use? ASCVD, we should be using either a GLP-1 receptor analog or an SGLT2, pretty much as first-line therapy. Okay. Now, does the PBS allow us to do that in Australia? No, but the TGA does. But why not use it with metformin? We would use metformin as foundational therapy in a lot of our patients anyway. So what this is basically saying is that, sure, you can use metformin, but really our mind should be focused on, should this patient be on either a GLP-1 receptor analog or SGLT2? Of course, the HbA1c may not come down to target with one or the combination of metformin plus one of those agents, in which case it says you should consider using whatever you didn't use before. So you can use metformin, GLP-1, and SGLT2 on the TGA. That's an indication in Australia, okay? And overseas, for our overseas listeners, you can certainly use the combination of metformin, GLP-1, and SGLT2, costs permitting, okay? So this already shows you the centrality of the newer agents, such as the GLP-1 receptor analogs and SGLT2s in atherosclerotic cardiovascular disease, where that is the primary concern. But how about if the patient has heart failure? Heart failure as their primary thing, or heart failure as one of the components of their cardio-renal metabolic disease? Well, in that case, there's one choice and one choice only: SGLT2 inhibitors, okay? And then what if the patient has chronic kidney disease as part of their diabetes as a predominant complication, or that you think is the primary thing that we need to prevent or treat? Then SGLT2 is by far the preferred choice, with GLP-1 receptor analogs having a smaller role, because GLP-1s have been shown to perhaps decrease the progression of albuminuria. However, SGLT2 inhibitors as a whole, as a class, have been shown to reduce not only albuminuria, but also slow the progression of eGFR decline and also slow the progression onto end-stage kidney disease. Now, once again, I will ask you to have a look at this overall sort of picture and see how important SGLT2's inhibitors especially are in this new paradigm of thinking about treating cardiorenal metabolic disease. Yes, GLP-1 receptor analogs are there as well. They are more expensive for those markets where it's all privately purchased, but SGLT2s are absolutely at the center of thinking about treating cardiorenal and metabolic disease at the same time. Now let's quickly go on to the other side of the diagram where it says, well, if the important thing is to treat the glycemia and the weight, what should we use? If it's glycemia that's the real issue, GLP-1 receptor analogs are pretty good along with insulin, but metformin, SGLT2 inhibitors, and SUs are not bad at all. What if it's about weight loss? If it's about weight loss, or at least maintaining weight, then the GLP-1 receptor analogs and SGLT2 inhibitors are the preferred choice. Once again, showing that even your run-of-the-mill type 2 diabetes patients where cardiorenal disease is not the primary concern, GLP-1 receptor analogs and SGLT2 inhibitors are still to be a preferred choice because they offer weight loss, and we'll have a look at some of that evidence in a little while in a very brief way. They also offer very good levels of glycemic control, and we'll look to see exactly how much glycemic control you can get with SGLT2 inhibitors in a little while. But what about Australia? Now, these guidelines are, I think, important to cover today because of all the people in the room, you're all Australian practitioners. Some of the people online are from Australia, but it's also very important, I think, interesting for our overseas attendees to have a look to see what do the Australian guidelines currently suggest. Now, there are 3 major guidelines that I will show today, but they are all interconnected. Okay, the first one is the so-called living guidelines. And the second and third one is, I'll coalesce into one, the Australian Diabetes Society and the Royal Australian College of General Practitioners, the RACGP. Okay, so let's look at this so-called living guideline. Now, the living guidelines suggest that metformin is still the first line of therapy. However, if the patient has, once again, cardiac disease or any hint of kidney disease, then what should the preferred option be? The preferred option should be an SGLT2 inhibitor, and it's got a green dot next to it. What does that mean? The green dot means that we have a very strong recommendation for this treatment. If the patient has any hint of cardiac or kidney disease with their diabetes, please use an SGLT2 inhibitor first after metformin. What's the next stage down? Because often we can't get sometimes we can't get control, or the control worsens after a little while with metformin and SGLT2. Then after that, then you can consider adding a GLP-1. Or if the patient cannot tolerate an SGLT2, then you can change to a GLP-1. So here's a very strong stepwise approach here. Metformin first, then SGLT2, then GLP-1. And then after that, you can think about other sort of stuff. So conditional recommendation for DPP-4. So that means that we recommend it, but it's not as good as those first 2 options that we talked about. And certainly in the red, things like SU, it's recommendation against things like SU as our automatic second line after metformin. Okay, what if the person doesn't have CV disease or kidney disease? Then we could either add an SGLT2, GLP-1, or DPP-4 inhibitor. And they say, well, either one of those things will be just as good as each other in the patient without cardiorenal disease. This is the ADS and RACGP guidelines, okay? And they're sort of, I put them together because they are now very similar to each other. You know, one feeds off the other. And we have metformin as the first line of therapy. So what do we do after metformin? Well, the dark blue boxes are meant to represent the usual way that we approach things. And the usual way, it says SGLT2 inhibitor, GLP-1 receptor analog, or DPP-4 inhibitor. as your next line after metformin, with SU and insulin and TZD and acarbose certainly bringing up the rear, not very commonly used anymore. But again, it's got those green dots and yellow dots to show you that the green dots are truly the preferred recommendation, with the yellow dots being the slightly less preferred. So again, the RSCGP guidelines pretty much push towards either SGLT2 inhibitor or GLP-1 receptor analog as the second line of therapy nowadays in 2023. Now, why should they suggest that? All these guidelines, I think, are coming towards this sort of conclusion because SGLT2 inhibitors hit multiple beneficial targets for our patients. SGLT2 inhibitors have a good reduction in HbA1c. In the general population, the HbA1c reduction, for example, empagliflozin at 25 milligrams is minus 0.64% HbA1c. And in those people with a baseline greater than 8.5%, it's minus almost 1% at just 24 weeks. And don't forget that SGLT2 inhibitors cause weight loss. This message has been lost a bit recently with some of the reporting around other classes of medications. But in terms of weight, the general population, diabetes population, will lose 2 kilograms on SGLT2 inhibitors, such as, in this case, empagliflozin 25 milligrams. Those with a high baseline weight will lose more, and I will show you some more data later. And don't forget that SGLT2 inhibitors, such as empagliflozin, will reduce blood pressure on average by almost 5 millimeters of mercury, which is actually quite a lot. That's a big reduction in blood pressure. Let's have a look a little bit further at the weight, and I was privileged enough to present this data at the Australian Diabetes Society meeting a few years ago. First of all, the weight loss is from the fat mass. A lot of people are worried that, the weight loss that the diabetes agents cause is muscle mass, it's lean muscle mass. Actually, it's not. The majority, 90%, is lost from the fat compartment. So that's a good thing. That's a healthy way to lose weight. But here's some other data. Look at this. This is the overall population for these people who took empagliflozin 25 milligrams. Average loss 2 kilograms. But if your baseline BMI was greater than 35, then your weight loss was 3 kilograms. Okay, and this was at 24 weeks. If you extend it out to 76 weeks, those people who started with a BMI of greater than 35 actually lost on average 5 kilograms of weight. That's pretty good. Okay, so this shows why, especially the ADA guidelines, the ADA EASD guidelines, sort of say, well, if the patient's priority is to lose weight, you could consider either a GLP-1 or an SGLT2 inhibitor. Okay, and that's before we even get on to the massive cardiorenal benefits of SGLT2 inhibitors. Now, I show the data from the EMPA-REG outcome, which was the landmark study that was published in 2015 for empagliflozin, which showed a 38% reduction in cardiovascular death. And it's in fact the only oral diabetes agent to show a reduction in cardiac death over and above that of just glucose control alone. A 35% reduction in hospitalization for heart failure, a 39% reduction in new or worsening retinopathy. So you can see now that empagliflozin, I've shown you the data, will improve the HbA1c. It'll improve the weight. It'll improve the blood pressure. It'll improve cardiac death. It'll improve hospitalization for heart failure. It'll improve the renal outcome. So this is all from one agent. And I think you can see why now the guidelines are pushing towards things such as SGLT2 inhibitors, not even as second line, but in some cases as first line therapy. For those patients at particularly high risks of things like this, you would certainly think that you would want an agent that hits all of these things at the same time. As you can see there, the slide is now showing that empagliflozin is the only oral type 2 treatment that is indicated for the prevention of CV death in those people with type 2 diabetes and cardiac disease. But it's not just the benefits, it's how quickly these benefits accrue. I mean, we were a little bit disappointed in some of the cardiovascular outcome trials or intensive glucose control and how it took years, decades almost, for us to show a benefit. In some of these studies, empagliflozin showed a benefit in hospitalization for heart failure. The line started to diverge within 17 days. That's incredible. In terms of the composite endpoint of cardiac death and hospitalization for heart failure, they're separating at 27 days. In terms of cardiac death, it's within 60 days. So within 2 months of starting empagliflozin, you are making a material impact on hospitalization for heart failure and also on CV mortality, which is just amazing. But let's not forget that glucose control is still really, really important. I think sometimes something that is lost in this conversation is that, well, let's just use agents which can improve the cardiorenal outcomes, which is really important. But don't forget that glucose control itself is still important. Now, this is what I was talking about, which took years to manifest the benefit. So this was from the UK PDS, which showed that if you treated people to a lower HbA1c, then over many years, every 1% reduction in HbA1c will decrease lower limb amputation by 43%, microvascular disease by 37%, heart failure by 16%, AMI by 14%, and stroke by 12%. All of these statistically significant. And that's for a single 1% reduction in HbA1c. Additional reductions in HbA1c will give additional cumulative benefits of this magnitude. So don't forget that glucose control is still important. But the question does arise, as I said, if the patient is, let's say, on metformin and an SGLT2 inhibitor, and they're not well controlled in terms of HbA1c, what do we reach for next? Well, yes, you could use a GLP-1, but that is quite expensive, both here in Australia and also overseas as well. So we do need things that are easy and yet inexpensive to take. Things like fixed dose combinations of an SGLT2 inhibitor with maybe a DPP-4 inhibitor, which can reduce glucose as well, but in a very convenient, safe, and relatively inexpensive manner. So there is, of course, such a combination. There is empagliflozin, which is an SGLT2 inhibitor, plus linagliptin, a DPP-4 inhibitor, and that agent happens to be called Glycembi. So on this side of the diagram, in the sort of purplish green, are the single agents alone. The DPP-4 inhibitor in the purple, the SGLT2 inhibitor in the green. And they reduce HbA1c very nicely, 0.6, 0.7%. But you put it in a fixed dose combination, Glycembi, low dose, high dose, and you're getting HbA1c lowering of 1.2%. So you're getting the additional benefit of not just the cardiorenal protection from the empagliflozin, but the additional HbA1c lowering of the DPP-4 inhibitor. And you do not, of course, lose any of the weight lowering effect of the empagliflozin just because you're using it in a fixed dose combination tablet. And it is certainly approved on the PBS. So for the Australian audience, metformin plus empagliflozin plus linagliptin is fully supported on the PBS, unlike metformin plus SGLT2 plus GLP-1. You've got to pay for at least one of those on a private script. So this is why Glycembi is such a, I think, good option for our patients. I'll finish up here by showing you this fantastic wordy slide, which I'm sure you'll all memorize, about the prescribing information.
I might get Dr. Janaka to come and present his case, and we'll have a panel discussion following that.
I'm trying to go back.
So they're doing it.
Oh,
We can do it interactively,
Yes,
maybe, so that
absolutely.
in the context of time. So I think maybe if we get everyone.
That'll be perfect. So maybe we'll get everybody here because we're going to do more interactive discussion.
Hopefully you can see some of the slides, but I'll verbalize the case. Okay, so if we go back, I hope we got the right case.
So you got the case study, Dr. Janaka?
I think let me go. Yeah, I'm going to go back. Yeah. Okay, so let's go back. Okay, so right, let's go for it. Okay, thank you very much. Okay, we're good to go. So this is just a case, and it's really about reflection, and it's something we are very keen in the UK. Part of it is mandatory to do reflection on cases, but also where you look back and you think, what could we do better? How can we improve stuff? And this is a very simple case, but just hopefully there's some relevant points we could pick up on. So this is Eve. It's got a family history of cardiovascular disease, and I'm going to add a family history of kidney disease, because you should also ask about family history, not only of heart disease, because if you have kidney disease in the family and you have type 2 diabetes and your parent or your uncle ended up on dialysis, that puts you at super high risk of also getting kidney disease. And this was shown nearly 40 years ago by colleagues and researchers in the UK. So these are her medications. She's got diabetes. There's a metformin, glycoside, which is very common in the UK. This is, I call the triple therapy of the UK diabetes patient in primary care. Metformin, glycoside, sitagliptin, ramipril, statin. HbA1c is 8%. We use slightly different units, or it's 64 millimoles per mole, but 8%. Blood pressure, BMI, that's a EGFR. That's an albumin-creatinine ratio, which was done, which is great. She had relatively stable EGFR, but it's low, and the albuminuria, hopefully, if you remember my red heat map, puts her in that CKD group that's at high risk. Those are her lipids. And then she dies. And the question is, she dies from a cardiovascular disease, which is increasingly common. And we have lots of people, sadly, still dying despite optimal medication. Things are much, much better compared to 20, 30 years ago, but people still die with diabetes most frequently because of cardiovascular disease. So when we have a patient like this, it's not straightforward, right? I mean, we've got lots of things. Often in the UK, GPs have 5 minutes, sometimes 10 minutes, if they're lucky. They get paid the same, whether it's 5 or 10 minutes. And it's tough, right? And, there are lots of things happening. We have this, I think GPs are, I call them the gatekeepers. They are the kind of the holistic doctors who don't look at the patient just with one organ system. You know what's happening at home. You know often what's happened in the past. You know the family background. You know their address. You know what kind of location they live in. And on top of that, we have all these other objectives in terms of what we're trying to do, as you heard, in terms of not only prevent hospitalization, but making sure the treatment impacts on all of this. So I'm just going to go through this, and then we'll come back to the case, because I think it's just a general comment. And I guess we look at the medications she's on, and then we think, okay, are any of those drugs doing what we want them to do? Some are, in terms of HbA1c, but definitely the glycoside also has an unwanted consequence of hypoglycemia. Do any of them increase life expectancy? The statin does, the ACE inhibitor. Blood pressure is important, etc. And I guess it's about kidney disease. And we'll come on to that. But this is just a kind of concept of thinking of these key things and getting people to think that it's not straightforward. But, if we go back in time, and we saw her 6 years ago, the same patient, things have changed. HbA1c is 7.8%. She was only on metformin at that time. Things obviously progressed because in the last 6 years, we've added lots of drugs. She's on the statin. GFR is better, but it's 62, but she still has albuminuria at a very micro level, which is over 3 in the UK, but that's abnormal. And the question is, I guess, is to think, and it's a case for reflection and discussion. And I guess it's, if we were to vote, I don't know if people can vote, I think there's a slightly nihilistic view of option 1. Slider. Yeah, so I guess, so I think that's a rather rapid answer for 100%, but I'll wait for that to settle. Yeah, so I think may not be, so I guess there's a slightly nihilistic view that many people have, patients with diabetes is going to happen anyway. 30 years ago, patients with kidney disease never even got dialysis because they thought, you're not going to get dialysis. That's 30, 40 years ago. So I think there's a nihilistic view that this is kind of self-inflicted, which is not true. And this is inevitable, which is not true. And that's one option. You could have just added more and more tablets to get that glucose down, which is kind of what happened if you look back. And get insulin early. There's a few people who strongly advocate that. And there are some benefits, as you heard, for microvascular disease. And then add a gliptin. So I guess I'll go back to the case, and it'll just be interesting to get different people's views, because obviously we've got a unanimous view, and then we've got the questions in general. So we'll go back to that. So I think let's go back, if you don't mind, onto the case. And I guess let's start here. and it'll be good to have a discussion with everyone. It's as I said, a case for reflection. Obviously, you know what happened, so that's going to bias what you're going to do now, which is not always the case. But it's important to think what could happen, and which often happens. It may not happen to every patient you have, but it still happens. If you come to a coronary care unit, you'll see a lot of patients still with diabetes who have been admitted, if they're lucky enough to get admitted and haven't died en route to the hospital. Okay, so I'll pass it on and I'll let you.
Yeah. So because she died of a cardiac cause, and we know the cardiac disease is the #1 killer for patients with type 2 diabetes, I'm still going to go back to renal first, Bobby, about this patient. What could we have done differently in managing her in the choice of our therapies to have improved her outcome?
Thank you, Anita. Thank you, Janaka and Ted. That was excellent. So from a kidney perspective, I think it's important for all of us to recognize that as nephrologists, you would expect that our only job is to prevent our patients from reaching dialysis or transplant. And the fact is only 10% of the patients from CKD actually reach dialysis or transplant. It's not that because we're doing a great job here. We didn't have any medications for the 2 decades other than RAS blockers to reduce the progression of disease. But 90% of these patients actually die from cardiovascular disease. That's how important is cardiovascular disease in the context of CKD. And I always like to tell this to my audience that for every 1 patient with CKD who progress to end-stage kidney disease, if you think 20 of them die from cardiovascular disease, you can see the importance of why we would like to start using an agent which are literally 2 faces of the same coin. It has a cardiac protection and a renal protection. That's why we feel that both cardiologists and nephrologists needs to work together. And this interaction is not new, because if you go back to 1500 BC, you will know that, I'm not sure whether you're familiar, the fact that the kidneys and the heart are the only 2 organs left behind in the dead during the process of mummification to assist the disease in the afterlife. So that's how important is the interaction between the heart and the kidney.
Yeah, that's really useful information. So like for her, instead of her being on the metformin, after metformin, the sulfonylurea and the DPP-4 inhibitor, we probably should have gone and put in probably in retrospect an SGLT2 inhibitor earlier when her A1C was still in the 7s.
We would do things very differently, but we can't do that thing just yet.
Yeah.
But I would, if given an opportunity, this patient should have been on a metformin and an SGLT2 inhibitor almost simultaneously for various reasons.
Yeah.
Metformin for glycemic control and SGLT2 inhibitor for organ protection. That's important. And one question that often comes up is when you actually won't start a metformin is your GFR. That's always been a problem. Right? So up to a GFR of 30, you can start metformin. It's adaptive dosing that comes to the point, but it is safe to start metformin at that stage.
Ted, this patient then finally came of an A1C above 8, overweight, slightly declining renal function. As a GP, what are we going to handle? And her CV risk, of course. So how are we going to manage what do we prioritize?
Okay, so I mean, it's exactly as Bobby has described. The fact that this person has out of control diabetes, so 7.8%, with an eGFR that is already a little bit compromised at 62 and a UACR of 6, that should be ringing alarm bells. Okay, it's that presence of microalbuminuria which says that this person is at very high risk. Now, not every single cardiovascular risk engine has microalbumin in there, but almost every single one. If there is microalbuminuria in the risk engine, if you put that the patient has microalbuminuria, suddenly you're boosted into the very high category. And that's absolutely because, as Bobby was saying, people with kidney disease are at very high risk of cardiac disease. Another statistic is that we all accept that people with type 2 diabetes are at elevated risk of cardiac disease, right? That risk is 2 to 4 times that of the baseline population. If you don't have diabetes versus diabetes, the people with diabetes, type 2 diabetes, have 2 to 4 times the risk. But if you have diabetic nephropathy, then you are at 20 to 30 times the risk. So it's another order of magnitude above. That's how much the cardiac risk is, right? So no doubt we need to get the HbA1c down, but we need to get it down in a way that will help, that will target the complications that this person has right now and also is likely to have in the future.
Yeah.
And to tick all the boxes here, especially for the kidney disease and then later on the heart disease, an SGLT2 inhibitor would be the obvious choice, because the HbA1c is 7.8%, we could definitely get that down to target with the addition of an SGLT2, at the same time putting at rest in our mind that we are covering the kidney disease and the possible risk of cardiac disease further down the track as well. And then if you don't get the HbA1c down from there, then you think about the third agent that you're going to choose, DPP4, GLP-1, even an SU. But the next step here, to my mind, would be an SGLT2.
Yeah, so just rationalizing your therapy choice after metformin to say, is this drug only glycemic or a benefit, or it's got more than that?
Yeah.
And as Dr. Janaka said, renal, when you start to see renal function decline, is a big red alert, because that's, you know, portending a really bad prognosis, not only just in cardiovascular outcomes, but the longevity. You're taking away 16 years of life in that patient.
Yeah, and I think we have data from empiric outcome that in high-risk patients with cardiovascular disease or, you know, some form of elevated vascular risk, that typically a 45-year-old will get 4.5 extra years of life. And I think, you know, we must be thinking, it's not these kind of long-term studies comparing a little bit of HbA1c to the other. We actually now have therapies that are organ protective, but also life-saving. And it's about choosing the right patients always, but also offering these things early.
And there's a question as well that's come up, because we've been talking about the drop in EGFR on commencement of SGLT2s or even sometimes ACE inhibitors. What is an acceptable dip? What's the cutoff?
So this is a very common question, and I appreciate, as Bobby said, sometimes you do have to test the kidney function, or it happens by chance because someone has tested it without knowing the background. So we look at a 30% rise in serum creatinine, and this is a historical thing, or an absolute drop in EGFR of greater than 10 mils. I start getting worried when it falls by more than 15 mils. This is in the UK. The first thing we do is repeat the test because often a kidney function is done in a dehydrated patient who's unwell, who has walked in, you know, it's a hot day. So always repeat the test, ensuring that the patient is clinically stable.
Correct.
If it drops by more than 15 mils per minute in terms of absolute value of GFR, please also think of other reasons, because patients with diabetes have lots of things going on. They could have taken a non-steroidal. They could have had their diuretic quadrupled by the heart failure doctor. They could have had a prostatic or a urinary infection, etc. So look for other causes, but if there are no other causes, 15 mils per minute is a concern. But there's also lots of nice data that shows that actually that initial drop also tells you that this is a responder who's going to have long-term kidney benefits. So like with ACE inhibitors, we know that you get that drop, but those who have that little drop actually do better. For kidney. So and the same with the SGLT2s, that initial drop is actually telling you, as we heard, that it's resting the pressure in the glomerulus, giving the kidney a bit of a break, but also it's giving you a sign that it works better. And in most clinical trials, just to reassure people, less than 5% of people had a fall in EGFR more than 15 mils. So it's rare.
It's a good thing to happen, actually.
Yeah, and indeed, I think another very reassuring thing from the clinical trials is that in every single clinical trial, those who took SGLT2s had less acute kidney injury and development of end-stage kidney failure than those who took placebo or comparator. So in fact, there's less kidney injury with SGLT2 rather than more.
So rather than us worry about them being nephrotoxic, it's actually renoprotective. So we should not be worried about that.
Yeah, I might just also add on that even after years on a patient being on an SGLT2 inhibitor, if you take them off the SGLT2 inhibitor, the GFR improves. Right? So
Correct.
this is purely hemodynamic.
Yeah.
Nothing happens on that.
Absolutely. So, Dr. Janaka, your patient, you know, she had started to show signs of renal impairment. As GPs, are there any almost flags for us to know this patient is high? You mentioned family history. You mentioned some other risk enhancers or something that makes us think, okay, I need to watch this patient.
Yeah, so obviously we've got the EGFR there and also the albuminuria. As we said, it's a simple test, often not done, but it's useful. It's a biomarker of kidney and cardiovascular risk. It's the trend in EGFR. It's a family history. I have a particular concern about young onset type 2 because this is a very vasculopathic type of diabetes. So to me, a young age of onset, and again, from a bias of work, very multicultural clinic, ethnicity.
Yes.
I strongly believe in my 20 plus years of experience that ethnic groups respond differently and have different inherent risks.
Yes.
So the African Caribbean and my South Asian and my Southeast Asian patients exhibit similar phenotypes. So I look at age, family history, ethnicity, EGFR level and trend, albuminuria, and that an early intervention. Don't wait for the GFR to drop below 30 to get activated.
I think we got the same scenario here in Australia, very multicultural. We have lots of ethnicities. So I think a final question, there's a question come through about when do we look at creatinine clearance versus EGFR?
You never do creatinine clearance ever. Please stop doing that.
That's a good answer.
Absolutely no requirement for doing two things. No creatinine clearance and no 24 urine protein. End of story. Just a urine albumin ACR, GFR estimation, and do not forget the blood.
Yes.
I think all along this conversation that we're talking about, we have been focusing so much on the GFR, a little bit on the ACR, but we often forget the blood pressure. From a kidney perspective and for a heart perspective, it's important that you check the blood pressure and medicate accordingly. I'm not expecting all of you to know the ins and outs of, glomeruli or things. If you could just check the GFR, blood test, ACR testing for the urine and the blood pressure, and then medicate accordingly. Just make sure the patients are on a RAS blocker, followed by a calcium channel blocker, followed by a diuretic, and then a fourth line agent for spironolactone for your blood pressure. You've done your job.
Yeah.
And I just want to add, ensure the RAS is optimized.
Yes.
50 to 60% of patients with CKD and heart failure still globally do not have the RAS inhibitor optimized. And that's key. It's not just I call it homeopathic Ramapro, 2.5 milligrams. It's fine if it makes you feel better, but it's probably not making the kidney or the heart feel better.
And I think as a group, you're actually doing really well because the uptake of RAS blockers was only 20 to 30%. We are already seeing an uptake of an SGLT2 inhibitor much more than what we had anticipated for. So all you out here, you guys are doing a fantastic job. So well done.
Yeah, I think the single most effective intervention we GPs do is manage blood pressure well and manage glycemia well to prevent coming to this stage at all. So I think we've got the panel discussion. So about sort of just the cardiorenal metabolic, I guess, interface discussion.
Yeah, look, I might just sort of start off looking at, I know that Janaka put some numbers in terms of the socioeconomic and the health economics as well. The Deloitte Economic Access gave a report last year for Kidney Health Australia. And the numbers are quite staggering. So $41 is the cost of a patient's management of early CKD per year for Australia. And that number goes to $62,358 for the management of kidney failure. It's a no-brainer. $103 is the cost of a kidney health check, including GP visit. Now I know it's a sticky topic, but I'll let it aside. But a urine ACR, a blood pressure check, and a GFR testing would only come to about $108. What we can do with that, just $108 by detecting CKD early, is quite significant. So I think it is clear that unless you actually screen for these patients with CKD in your population, you can't start using agents like SGLT2 inhibitors, which has absolutely transformed the management of diabetes, of CKD, and of cardiovascular disease. So you must start looking at the risk population because you can't obviously keep looking at investigating everybody who enters your practice. It has to be targeted. And you have to screen patients, like we discussed today, for diabetes, for heart disease, family history of kidney disease, those who are obese, smokers. We often forget the smokers as well. And those who have previous history of AKI, they are also at risk for CKD in our population. So you might have to screen them. And just one last thought is that not everybody who walks into a practice who has got a proteinuria and a low GFR is diabetic kidney disease. I mean, of course, in the diabetic population, yes. But if you are looking at a slightly younger population and you think it's not correctly fitting in, don't forget to do a urine microscopy. Because for all you might know, this patient could have a glomerulonephritis. And you're just focusing on one thing here. A urine microscopy looking for red cells will take you in a completely different direction. So check urine at your practice. If you can't, if you're poor for time, a dipstick is good enough. If a dipstick picks up blood and a dipstick picks up protein in the urine, you can be rest assured the patient needs to be investigated further. a urine ACR definitely indicated in that patient.
Yeah, that's a really good tip. It's a simple test, but gives you a wealth of information. So Ted, I might get you to present your case so we can talk about early intensification, but maybe the panel members could still stay here because we are going to have the sort of Q&A soon after.
It's a very, very short case. So yes, please stay here. All right. So this is a much shorter case than Janika's. Okay. So this is Mr. Lim, who's a 66-year-old retired office worker. He's had type 2 diabetes for 5 years, and he's on metformin 1 gram twice a day, HbA1c 8.1%, and has stable cardiac disease. So he has established cardiac disease, but has not had his first AMI yet. Again, the eGFR is 59 and his ACR is 5.1. So, I mean, it is there on the slide, but I think that you can sort of think, well, once again, this is actually very, very much like Janika's case in that he's on metformin. His HbA1c is high, he does have cardiac disease, and he does have evidence of renal disease. So the question is, what are you going to put him on? Now, the slight difference here is that his HbA1c is not 7.6% or 7.8, is now 8.1. And the question is, would empagliflozin, let's say that we chose empagliflozin by itself, bring him down to an HbA1c of 7% or lower? And yes, it might. But the average HbA1c lowering of empagliflozin, even at 25 milligrams by itself, is about 0.6, 0.7%. Might not get him down to HbA1c of 7%. So what could we do in a very simple manner? Well, you could instead use a fixed dose combination. So that is empagliflozin plus linagliptin together. So that's Glyxambi, of course. And it is recommended by the various guidelines. There's a low risk of hypoglycemia. You get the weight loss benefits, but more than that, you get the cardiorenal protection from the empagliflozin, and it's a simple once a day tablet. So instead of adding another tablet and then an injection, or adding 2 separate tablets, let's say that an alternative would have been SGLT2 plus sulfonylurea. Instead, you could just add 1 single tablet once a day, and then you would probably reach your HbA1c targets. You'd certainly be looking after his heart and his kidney at the same time, and in a very simple to use sort of way. And as I said, very, very easy.
Does anybody else have another opinion of anything else that would be done differently? Could you have another way to skin the cat here?
I might just, I think that's a good way to say it. Is, Ted, if I say, can we go to empagliflozin at 25 milligrams here just to improve the glycemic control, given that your HbA1c is at 8.5% or 8.1% and your GFR was, I think it was 59. So the SGLT2 inhibitors would still be efficacious for glycemic control here. What are your thoughts between 10 milligrams of empagliflozin and 25 milligrams of empagliflozin?
Yeah, so that's a really, really insightful question from Bobby. So, unlike for heart failure and unlike for kidney disease, there are 2 doses of empagliflozin, right? So for heart failure and for kidney disease, 10 milligrams of empagliflozin is enough, all right? And it hasn't been studied whether there's additional benefit from 25, although indirect evidence from the EMPA-REG outcome shows that there is just benefit at 10 milligrams. There's no additional benefit from the 25 milligrams. So if you think of the heart and you're thinking the kidneys, then 10 milligrams is enough. So why do we have the 25 milligram dose of empagliflozin then? The 25 milligram dose of empagliflozin has slightly more glucose lowering and slightly more weight lowering than the 10 milligram, but it is not huge. Perhaps I will go back to my previous slide here. Okay, it is very close. There we go. So, gosh, it's even gone the other way here. But you can see here that 10 milligrams, you're getting a minus 0.7%, and at 25 milligrams, you're getting minus 0.6. That was just a sort of chance effect of this trial. But in fact, most of the time we see slightly more, maybe about 0.8%. So what the message here is that, yes, you do get additional glucose lowering, and you do get additional weight lowering, by the way, as well from the 25, but it's not that much. So let's go back to weight again. the weight lowering is, let's say, about 2 kilograms on the 10 milligram, and it's about 2.2 kilograms on the 25 milligrams. So you're getting slightly better glucose and weight lowering, but in fact, 10 milligrams is doing the vast majority of the heavy lifting here. So whenever people then ask me, well, what dose of empagliflozin should someone be on? It's almost a small joke of mine to say that there is no wrong dose. As long as they are on the empagliflozin, that's the important thing, because 10 milligrams is already going to get you the cardiac and the renal protection, and there's no difference between the 10 and 25. Yes, 25 will give you slightly more glucose and weight lowering, but it's not that much more than the 10. So as long as you're on a dose of empagliflozin, you're going to get the vast majority of the benefit. I personally do not stress too much about what the dose is of the empagliflozin. I just care that they are on it. That's my message.
So can I be the devil's advocate here? Yeah. And let's say we're talking about glycemic efficacy, whether we go 10 or 25, but what about the non-pharmacological therapies? What about the lifestyle changes and trying to achieve weight loss with that and get the A1C down?
Yeah, look, it's absolutely essential. And don't think that I'm trying to discount the importance of lifestyle changes. Modifying what you eat and how much you move around is incredibly important for our patients. I talked about losing fat mass versus muscle mass. And the easiest way to retain muscle mass and to lose further fat mass on any of these medications is to do exercise in addition to taking them. So whether you're on a GLP-1 or an SGLT2 inhibitor, the best way to get better, more healthy weight loss that is kept off longer is to also encourage more exercise. So exercise is absolutely key.
Thank you. So we might move into the Q&A. Please keep putting questions through Slido. So I'm just going to start with blood pressure goals in a patient with chronic kidney disease or DKD.
130/70 for diabetic kidney disease. But also it depends on your age of the patient. So if you are looking at a slightly younger patient, now age can be defined in various ways. I won't go into that. But 130/70, if you get 130/70, I'll be very happy. But if you're able to get down to 110/70 in a younger patient who want to cut down proteinuria, I'll be even more happier. But 130/70 would be your target.
Yeah, as long as we do it safely, whatever we do.
And also, yes, and the combination and the drugs that we get there, I think that's important because we often tend to forget that. We have patients coming with 10 milligrams of amlodipine and 5 milligrams of ramipril to control a blood pressure of 130/70, and you say, yeah, you achieved that. Oh, yes, fine. But if you're having proteinuria and if you've got CKD, I would like that blood pressure of 130/70 achieved by 10 milligrams of ramipril and 5 milligrams of amlodipine. So you preferentially use a RAS blocker over other agents.
Exactly.
I was just going to add that I think for our younger patients, we may not have the evidence, but if they have, I follow exactly what you do. But also, again, there's a bit of discussion. It's topical. It's looking at early morning blood pressure and nighttime blood pressure. And in many of my renal patients, they can tolerate a lower blood pressure if you give some of the treatments at night. And it's about compliance.
Yes.
Number one. Not everything is only as good as if you take the tablet,
Correct.
as you correctly said. So number one, if you're going to take it in the morning, that's great. But if you can take it in the night, that's fine. But also, we at least in my practice, we often dose blood pressure tablets at night, especially to get much better early morning blood pressure. And also people can tolerate a lower blood pressure, especially the younger people are often up and about in the daytime. And if they're in a very hot country as well, which is not common in London, but it can happen for a few months of the year, it kind of helps in that kind of effect as well. So it's timing, but also compliance.
Yes, and what works for that patient. And I think some of you mentioned that, we shouldn't be scared by just the blood pressure level. It's more about symptomatic hypotension when we're trying to stop drugs or lower doses. And it's not that just because they've reached 100 on 80, we have to 70, we have to stop the drug if they're not symptomatic and they're not at risk of falls. Because we worried about falls in terms of hypotension.
True, and that's why I need to qualify that statement. In the context of heart failure, symptomatic hypotension. Yeah. But if it's not heart failure, then I would be very careful about dropping your blood pressures in your elderly patients down, because they may or may not have symptoms on that, but that's very risky.
Yeah.
In fact, if you actually drop your blood pressures a bit too low in that elderly population, you're actually risking dropping your kidney functions as well because of renal hyperperfusion. So I would not recommend that in that population.
So it's a fine balance.
It's a fine balance.
Yeah. So how important, Andrew, we talk about heart failure and we always talk to patients about daily weights, fluid restriction. So what is the advice we should give, which is practical and doable?
Yeah, that's a tricky one. I mean, the trials that have been done on salt restriction and fluid restriction uniformly don't work. It can be harmful. So that's not to say that excessive sodium intake and excessive fluid intake cannot be harmful. In some people it can, but common sense rules.
Yeah.
There is no evidence that going for strict sodium restriction will be any benefit whatsoever. What we should be getting good at is managing fluid balance and managing diuretic dose. So I train all my patients who are capable and interested on how to self-management their diuretic dose. You set parameters, you ask them to weigh themselves after they've been to the toilet every morning and keep an eye on it and let you know. It's a simple way of doing telemonitoring, if you like.
Yes.
And they get very good at it and they know exactly what to do. And they can judge their diuretic dose and makes lifestyle better, because there's nothing worse than a big dose of frusemide and then being on a bus and needing to go. So those simple management are very important. The general lifestyle advice, and I'm glad we've come to lifestyle factors, because I look at protecting patients from complications of disease as defending a village from outside attack. First of all, you have general protective measures, which is avoiding adverse lifestyles, improving lifestyle recommendations, smoking, alcohol, regular exercise, optimal body weight. Then you have specific defenses, controlling blood pressure, controlling your lipids. And then you have magic bullets, where you find that if you've got kidney disease, RAS inhibitors improve outcome. You've got heart failure, SGLT2 inhibitors. So we need those 3 levels of defense for our patients.
Yeah, good, very good advice. So, Janaka, you mentioned ethnicity, age, family history. And in Australia, we have the First Nations people, the Aboriginal and Torres Strait Islanders, who we know are at very high risk of renal disease. So, I mean, I don't know whether you or Bobby have any tips for the audience about this special population.
Oh, yeah, absolutely. It's one of the 8 risk factors for CKD that you need to screen for in your patients is the indigenous population, and they do have a significantly higher risk. Whether their SGLT2 expression in the First Nation population is very different from that of a Caucasian population, I think we are probably not very clear about it, but the efficacy of these agents would still stand good, and I think would definitely still do that.
Yeah.
Yeah, so I think in general principle, it's also looking at the renal function and the albuminuria on top of everything, but appreciating then if a person comes from a high risk ethnicity, that your surveillance approach needs to be more individualized. I think we have this concept of a one size fit all.
Yeah.
And the reality is that we cannot deliver, at least I cannot deliver that service in London, and we have to have a degree of prioritization.
Yeah.
And it's about identifying people who you think need more enhanced surveillance and also following up on it, because a lot of people don't want to come for appointments, they don't take their medication. So there's a high risk group that we should try harder.
Yeah.
And I appreciate the healthcare delivery is very different in Australia, but there will probably be a point where there will be a lower risk group who you may need to give less attention to cope with the high risk group who we should pay more attention to.
Is obesity a risk factor?
For sure. So obesity causes proteinuria on its own. It activates renin-angiotensin system, sympathetic system, and the presence of obesity per se on top of type 2 diabetes, but also lifestyle. I think, I often say if you're having your 6 or 7 fish and chips a week, your RAS inhibitor is not going to work. No. So, it's simple things that are really important.
And just also to add on to the ethnicity aspect, I think we should also bear in mind we are a multicultural society here, and of course there are colleagues who are listening elsewhere. Diabetes, any of Asian population, they have high risk for diabetes. Diabetes is our birthright, and I'm an Asian, I can tell you that. It's our birthright. I mean, so if you are seeing anybody of Asian background coming to you for the first time and haven't checked for diabetes, please do. If a patient has got a family history of diabetic kidney disease, then their risk of developing diabetic kidney disease goes up very, very high. So that has to be an absolute red flag if you have a family history of diabetic kidney disease. Just keep that in mind.
Yeah. So there's a question here. Should metformin still be titrated to a maximum dose of 2 grams daily when the patient is still on an SGLT2 inhibitor?
Okay, so I'll split this actually into 2 parts. The first part is, should you go to the maximum dose of metformin before you think about adding a second agent such as SGLT2? And the answer there is no.
No.
Okay, try try and think about if the patient really needs an SGLT2 inhibitor, or indeed any other agent, then you add it in before you reach the maximum dose of metformin. There's many reasons for this. First and foremost, if you think that the SGLT2 is of benefit, add it in early, do it right now. But the second thing is that the gastrointestinal side effects of metformin is linearly related to the dose. So the higher your dose of metformin, the more likely you are to get a side effect, and the patient will come back and go, well, I've stopped everything, right?
Yeah.
So you might as well use the second agent before you reach the maximum dose of metformin. The early use of combination therapy is again advocated for by various guideline bodies around the world. I won't go through that in detail, but it says you should add that second agent before you've reached the maximum of the metformin dose. But the second part of that question is, let's say that you're now on non-maximal metformin and you're on the SGLT2, your HbA1c is still high. Yeah, absolutely. At that stage, then you try and push the metformin to its maximum tolerated dose.
Yeah.
There's no harm in that situation of increasing the metformin. And you can keep the metformin going until the eGFR is well under 30 permanently.
And Andrew, would the same apply when you're looking at the 4 pillars? Instead of maxing out the dose of one of those, we try to add in a little sprinkle of everything and then up titrate.
There's no specific randomized controlled trial, but very detailed registries have shown it's preferable to be on something of all 4 than maximizing 1 or 2.
Yeah.
So absolutely, get something of all 4 on as quickly as you can.
Yeah.
Then you can consider up titrating later.
Yeah, which we GPs do intuitively. Even in blood pressure, we do the ACE and then we add the CCB or we add the diuretic. We don't keep maxing one and then wait for the next one. So there's a question: in some countries, a urine ACR is hard to perform. Will a urine dipstick suffice?
If you can manage to do a urine dipstick, yes, it's not the same equivalent of an ACR, but I acknowledge that microalbuminuria testing in some of the Asian countries are very expensive. It's not easy. So the urine dipstick is the closest that comes to that. Point of care testing for ACR is not currently recommended. When I say it's probably not that valid, but we are lucky, fortunate to live in a country where we can actually do it, but you're right. If you can't do anything, at least a dipstick.
And there are some urine dipsticks at least I know that are used in South Asia, which are not very accurate, because obviously with the urine dipstick, you only pick up proteinuria.
Yes.
But there are some dipsticks that can just give you microalbumin, but not quantified.
Correct.
So it's a lot cheaper.
Yeah.
But remember, if you're only relying on your urine dipstick, you're going to find patients but there are strips, especially in South Asia, which just give you a microalbumin result rather than a value. And they are less expensive, obviously, than a urine ACR. But any urine is better than nothing. Another question we get asked often is, does it have to be early morning? Does it have to? And the question is, any urine is better than nothing, but you also need two results to confirm the diagnosis before you put someone on a medication for the rest of their life.
Yes.
And one of those tests has to be on a first voided sample to confirm the urine ACR. So it's about opportunistic testing. These patients coming into your GP practice, if you see this guy coming once a year, and if you don't catch him, get a urine test done. If it's positive for protein, then definitely ask for a urine ACR.
So we've heard about the RAS activation, the sympathetic nervous system activation, and the importance of using drugs that target those systems. But in what sequence? What is the best sequence? RAS inhibition first, and then SGLT2 inhibitors, or whatever. So there's a question as to, is there a better way to do this?
Okay, so the KDIGO pyramid, in 2020 and in 2022 looks vastly different. So the recommendations, which may not currently apply to the Australian population yet, but the recommendation is that all your diabetic kidney disease patient needs to be on a metformin, needs to be on an SGLT2 inhibitor, needs to be on a RAS blocker, and needs to be on a statin as well. They are the 4 foundational agents. And then you go goal-directed on the top of it. If your glycemic control is not achieved, your next agent expectedly is supposed to be GLP-1 receptor agonist. And then if your proteinuria is not controlled, despite being on a RAS blocker, despite being on an SGLT2 inhibitor, then your expectation is to move to a non-steroidal MRA. We haven't reached there yet, but that is the ideal world to get on there. But in terms of sequence, of course, if the patient has got diabetes and has got proteinuria, you can start the patient on metformin, an SGLT2 inhibitor, and depending on the blood pressure, you will actually start the patient on a RAS blocker anyway. So that's where the RAS blocker comes over an SGLT2 inhibitor.
And the reality is that most of our type 2 diabetes patients are already on a RAS blocker, because very few of them come with just plain diabetes. So there's a question here about what do we do when the EGFR approaches 30 in heart failure? I think we did say that SGLT2 inhibitors can be used down to 20 EGFR.
I'm going to clarify that. So SGLT2 inhibitors can be used in Australia for a GFR of 25 and above. And once you start the patients on SGLT2 inhibitor, you can actually continue the SGLT2 inhibitor until they reach dialysis. You do not stop SGLT2 inhibitor after you started SGLT2 inhibitor until you reach dialysis.
Yeah.
Because that's what we have so much of evidence to say the benefits of this is not reliant on your GFR.
So Bobby, that sounds really good in principle, but I think we GPs are very PBS and PI centric. So when you look at the PI of a drug and it says, then we kind of tend to a little bit get scared
Pulling
down
back?
to end stage. Yeah.
Pulling back, is that what
Yeah,
you're saying?
yeah.
Is that for initiation or for withdrawal?
No, I think when the patient's already on it and they have sort of gone into a decline and they're reaching a GFR, say, of 15 or 12.
I'm not sure. Is
We
that what the PI says?
Is it maybe you're right, it's initiation.
Guidelines
Yeah.
all over will say that once you initiate, you can
Do not
continue.
stop.
Do not stop
Okay.
until GFR, yeah.
But I think you raise a valid point, and something we should do better as specialists is give the kind of the pass.
Yes,
so what I
pass.
do is, we write to the GP, and when they ask, and say, in the opinion of me, we will use this drug right down, and you have that to guide you from a medical, legal, and other perspectives. So
Be
I think-
reassured that.
and that's where the specialists, at least in London, it's a very common question for lots of drugs, not just SGLT2s, which are, in different, and the consultant or the specialist should write the letter, they believe in it, they should, and say, this is what I recommend. And for this individual patient, the risks are outweighed by the benefits, and we would continue the therapy. And that's where actual proper medicine is important.
Because deprescribing
Where people take
occurs in general practice.
responsibility, not just follow a guideline.
Yeah, I think there's a couple of important points that this raises. And the first one is that the restrictions for initiation are different to the restrictions for continuing. So my understanding is that in the Australian context, empagliflozin can be started with an EGFR of greater than 20, but then can be continued regardless of EGFR. And I will give the analogous situation of HbA1c. So a lot of these diabetes agents, especially the newer ones, you cannot initiate unless the HbA1c is over 7%. But you can continue it if the HbA1c falls below 7%. So it says nothing about continuation.
Yeah.
Okay. So you can continue it.
And that's a really important message for us, because I think that's why we wrongly sometimes deprescribe drugs, just for the fear, which is not founded. It's an exaggerated kind of fear we have in our minds.
Oh, yeah. And there's one last thing. Don't forget that at the lower EGFRs, there's almost no glucose lowering from the SGLT2 inhibitors. The glucose lowering effect from SGLT2s is dependent on glomerular function. So do not expect there's any glucose lowering at all whatsoever once the EGFR falls below about 25 or so. So you're going to have to rely on other agents to bring the sugars down.
So on that point, we were talking about declining renal function. When do we refer the patient to a nephrologist?
For us,
The Australia is the key.
I'd love this. So yes, I think the gentleman asked me during my lunch break as well, when do you refer and why there's a waiting list for these patients to be seen? I totally acknowledge that. I know, and I acknowledge that. So the expectations from a general practitioner in Australia, the Kidney Health Australia guidelines is a number 30. GFR of less than 30, a urine ACR of more than 30 is an automatic referral to a nephrologist. Now you might ask, I'm sending this patient with a GFR of 59, you're taking 1 year to see him. And that's because we are not expecting, you should not be expecting us to actually manage those patients, because CKD is a disease of a general practice management. It is not about nephrology, right? We want you to take the center stage. We want you to screen patients for CKD and start managing these patients. If you're giving the patient a RAS blocker, and if you've given the patient an SGLT2 inhibitor, and then you send the patient to us, you've got nothing else to offer, because you've already done what's out there, and these are going to change the management of the patients. So broad guidelines, number 30, GFR less than 30, ACR more than 30, consider referral to a nephrologist.
So in the UK, we also have rate of change of GFR as a criteria.
Yeah.
And if your GFR has fallen by more than 15 mils per minute per year, that's a criteria for referral. It's actually for non-diabetic causes.
Yeah.
And this is important because your diabetic hot kidney, if you like, generally will fall at around 5, maybe 10 in the high-risk population. But if it's falling by more than 15 mils per minute, it's looking for those non-diabetic, potentially reversible causes. So I think, just to reinforce what I said,
Yes.
trends.
Correct.
Early identification.
And not
And
wait
also,
for.
yes, and also when you send the referral to us, we are not going to just look at it and say, oh, this patient needs to be seen in 90 days or needs to be seen in 180 days. We use the kidney failure risk equation to dictate, to say which of them needs to be seen ASAP.
Yeah.
So that's also
Stratify their
has to
urgency.
stratify.
Right. I think. Yeah. Yeah, couldn't we just get the mic for you if you're going to ask the question, because we can't actually hear. So for the
What
benefit.
he said was that
Yeah, sorry.
No, it's okay.
Yeah, okay. So I think you heard the question, right? We might.
I think we're moving on.
Yeah, we're moving on. Okay, so in the interest of time, I think we will wrap up because we've had a lot of very good discussion and it's been quite, I think, interesting for us to get some real good clarifications on a lot of contentious issues and our conundrums in general practice. I think we've today learned that type 2 diabetes patients are not just purely having a metabolic disease and just a disease of glucose, but they are at risk or already have cardiovascular disease or renal disease. And I think we've heard from all the specialists that as GPs, we need to be really looking out for these risk factors in these patients, identifying them early. And so the cardio-renal metabolic interconnection means that we cannot just focus on one system alone, but treat them all together and use drugs that target that. I think TED has demonstrated that our treatment paradigm for type 2 diabetes managed has definitely moved away from glucose centricity, and our own local guidelines reflect that and ask us to look at the patient more comprehensively, look at the patient sitting in front of you. Is this patient at risk of or already has cardiovascular disease and at risk of or already has renal disease? And then choose preferentially after metformin the drug that is renal protective and cardioprotective rather than just lower the glucose by any means. I think we've learned from QKPDS that glycemic control is important. Early intensive control is important, but that's not the end all and be all of managing our type 2 diabetes patients. Given that they die most often from cardiovascular disease, I think our number one priority is to protect them from that lethal consequence of type 2 diabetes. And we've heard renal disease is also a very bad prognostic, I guess, element of the whole system. So we need to really focus on the renal system as well. So I think GPs are ideally placed to manage these patients. And as you've heard, we are really seeing our patients through their whole journey of the disease, whether it be diabetes, heart, or kidney. So we should be really there proactively monitoring them. As Janaka said, look at the trend, focus on what's happening, intervene early, and sort of manage everything about the patient right from diagnosis, both in terms of pharmacotherapy and non-pharmacological strategies, which are lifestyle interventions. But as well, I guess, be the counselors for our patients in order to emphasize to them the importance of why they're taking a particular drug and what is it going to do for it. I think patients are much more likely to have good adherence if they know what's in it for them. And I think we need to make the complex simple even for ourselves. Think, okay, here's a very simple pathway. TED brought out that beautiful, I guess, algorithm. But I think most of all as GPs, we struggle with this multiple guidelines for multiple diseases. What we would like is an integrated algorithm, which is patient-specific, troubleshooting, and tells us how we actually navigate through this complex maze. And like you said, more discussion, more interaction between the tertiary system and the primary system with good discharge summaries, timely communication, clear delineation of responsibility, saying, I'm doing this, you follow that, or I'd like you to initiate this and up-titrate. Because we are time poor, we need very good guidance. So I think basically it's a teamwork, and we're all here for the patient, and we need to just work together rather than make it your or my responsibility. And I think with that, I'd like to probably close my comments as a GP standing here, that I think we all have got medications, we've got good expertise, and I think we just need to use it, because I think it is becoming easier rather than difficult now. And so we should really run with it. So I'd like to thank you all for the time you've given up today, the wonderful questions that you've put forth, because that stimulated a lot of really good discussion. I want to thank our organizers, BI Lilly, who put up this event, which has been really useful to all of us, you'd agree. And of course, I'd like to most of all thank our wonderful speakers who have given their time and shared their expertise with us and given us a lot of really good information. So a big thank you to all of us. Don't forget, on your tables, you've got that QR code, which is for evaluation. So please give us honest, brutal evaluation of today so that we can do it better next time on the table. We'd love to do that. And thanks to the AV team for making it possible for us to be heard. Thank you.
Thank you very much. So we'll sign off there on the online people, and thank you for joining all around the Asian region and also in Australia online. That's wonderful. So for the people in Sydney,